So the route of transmission is very similar to HIV and hepatitis B. It's these infected fluids that are the infectious cause, but you're right, when we look at, let's go back to how many healthcare workers got HIV as part of the treatment team, and typically it was needle sticks. We knew about the break that occurred. Something happened. There was a needle stick, there was some kind of a spill into an eye, there was some abrasion already existing on the skin, and then a spill of fluids on the skin. And so far, what's known about these 3 cases of secondary transmission and what is known about some, but less data on some of the cases in Africa, it appears this is a little bit different. So does this mean it's a different route? No. What people believe is probably it's going to end up to be the viral load is probably going to be a piece of this. So the amount of viruses, particles that are in at the end stage of disease is important, and there may be other differences about the virus as well that we don't yet know about. So we're treating this as if the route of transmission seems to be well demarcated. The distinctions between other things, a good example would be SARS versus routine influenza. Okay, same route of transmission. SARS was more contagious. It had an increased risk of contagion, measles more than some other things that had the same route of transmission, but the risk of infection after a small unit of time exposure is different. This one's on the higher end, it appears, and that's what we're taking these added precautions about. And the reasons right now are not well elucidated, but right now what we do know is at the end of disease, where people really have lots of diarrhea and are just about dying or even in the dead body at the beginning, viral particle load is very, very high. So that's at least one distinction. It may be the most important one, but we don't know.